Um, Dear Chairman, ladies and gentlemen, good morning from my side, and thanks for having me in this panel. As a title of my lecture, I was given quite a clear question, and if you want to hear the short version of my talk, then I just say a clear yes, and we go on. But as I was allotted 15 minutes, so I think I have to give you some of the evidence on which I base my answers. So let's go. Okay, so I have nothing to disclose, and I think. Okay, so what's the background? So what are the facts? What do we really know? So we know that regional metastasis is a poor prognosticator. It's a risk for recurrence and survival. We also note that occult metastases do occur in approximately 20% of the clinically staged N0 patients, so there is a need for action. We do know that especially in intermediate thickness melanoma, we have quite a high probability of neck nodes, occult disease, but we have a low probability of distant metastasis. So that's the group of patients, the cohort of patients that might benefit from addressing the neck nodes. We know that elective neck dissection in the studies that have been conducted so far has shown no advantage in survival in intermediate thickness melanoma. So generally elective neck dissection is not recommended anymore. We have a problem with statistical power because you have always 80% of patients that do not have the disease, so it's almost impossible to get good powered studies to prove the advantage of an intervention. And that was the problem with all elective neck dissection trials too, because they were all underpowered. So, but what we certainly know is that if you send just 2 or 3 sentinel nodes to your pathologist, you will get a better staging with step-zero resection and immunohistochemistry compared to that what you get when you send him a neck dissection specimen that's just routinely worked up. So that's approximately what we know. I think this machine doesn't really work. But okay, so what's the concept for those who are not very familiar with the concept of sentinel node biopsy? The hypothesis is that you have kind of a first echelon node, a first draining lymph node, which gets all the metastases first. So and that all the rest of the nodes are just reached subsequently. So if you can identify these nodes or this group of nodes, you can examine this group of nodes and they are tumor-free, so your chance of having no metastasis in the remainder neck dissection is very high, so you can, there's no need to do a neck dissection then. But if you find a positive sentinel node, then you have to go on, and usually neck dissection is advocated. The principle is that you mimic the lymphatic drainage, so the way the tumor cells go, you mimic it by colloids that are usually with the kinesium labeled, so you can detect them during your surgery. So lymphatic mapping in the melanoma patients is usually done with the triple diagnostic technique. It's a little bit different from the mucosal squamous cell carcinoma. In mucosal squamous cell carcinoma, most sensors do not use the blue dye anymore, but in melanoma, I think it can help because it's just the visualization allows for better identification of the lymph node. So lymphatic mapping, you do that with conventional lymphoscintigraphy. You can do it either the day before or the morning prior to surgery. Nowadays, most centers use PET-CT. I think PET-CT is very useful for the surgeon because it gives you anatomic orientation where your sentinel node might be. And then you do the injection of the blue dye and the surgery. And during surgery, you just use your gamma probe to find the nodes. The most important work is done by your pathologist. I think step-zero sectioning and immunohistochemistry is mandatory for sentinel node biopsy. And that's quite a bit of work for the pathologist, but gives you quite accurate information on the status of your sentinel node. We have to look a little bit at definition of occult disease. Not any occult disease is micrometastatic disease. So there are definitions of what isolated tumor cells are, of what micrometastases are, and what macrometastases are, and mostly it's based on size. So that's what your pathologist should report, because this might have a different prognostic impact and might have impact on your therapy. So if you talk about sentinel node biopsy, there is no way not to just have a look on the MLST1 trial. I think that's the data we have. That's level 1 evidence, and I think we should have that. The final report was just published in the New England Journal, and I just want to go through the curves just with you to see what the evidence is and what we can extrapolate for the head and neck side, because that's quite a little bit different. So that was the trial design. You're very familiar with that trial design. You have an observation group. That means wide local excision and observation of the neck, and then treatment in case of nodal recurrence. And you have the intervention group with wide local excision and sentinel node biopsy. So that was the trial initially designed. That were the initial results. The most important fact is that there was if you look here at it's not that easy, this thing here. Okay, maybe without the pointer, you see that you see there you see the biopsy on the upper left corner, the biopsy group versus the observation group, and there was principally for survival. There was for the entire cohort there was no difference in melanoma specific survival. But what was clear that the sentinel node negative group did much better than the sentinel node positive group. So there was a prognostic impact on finding a positive sentinel node. And so that might be the group of patients, the cohort of patients that might profit from a kind of therapy escalation or adjuvant treatment. So there was a clear difference in prognosis. The other thing is the most recent report did a quite interesting thing. So they now looked at the intermediate thickness and thick primary melanomas separately. And so I think that was quite an interesting thing. Intermediate thickness melanoma means between 1.2 to 3.5 millimeters, and the thick melanomas larger than 3.5 millimeters. There is no doubt on thin melanomas, because there were too few thin melanomas in that trial, so there was no conclusion on thin melanomas. But intermediate thickness and thick primary melanomas, there we have the data. And the interesting thing is what we see here. You have on the left side, you have the on the upper side, you have the melanoma-specific survival. Left side for the intermediate thickness melanoma, on the right side for the thick melanoma. There was no difference for in the entire group for the observation group and the sentinel node biopsy group, but there was a difference in disease-free survival, especially in the intermediate thickness melanoma for the as an advantage for the sentinel node biopsy group. So I think that's the group where we see the difference. It's just in disease-free survival for the cohort that gets the sentinel node biopsy, is sentinel node biopsy positive and gets the immediate lymphadenectomy. That's the group that has a major profit out of this trial. What's also quite interesting is if you look at the cumulative 10-year incidence of nodal metastasis, you see the two curves. So if you observe the patients at the end of 10 years, the observation group has the same incidence of nodal metastasis as the sentinel node biopsy group, which means that probably all the occult disease, if you leave it in the neck, will then develop to clinically overt disease. So that's quite an interesting finding here. This is a quite quite a complex graph, but I think it shows you the most important thing about that trial. So I don't know if you can read that, but so the group that does really good is of course our two groups. That's the group that's going to be observed and that has no nodal relapse. And the other group that's doing good is the Sentinel node biopsy group that has a negative Sentinel node. So these are the two groups that have no nodal disease. They do very well. So the group that doesn't do very good is the group that develops nodal recurrence, or the group that has a false negative Sentinel node biopsy. So if you miss the node, your patient will have the same worst prognosis as the patient in the observation group that gets the the nodal metastasis later on. But interesting is the group which is in between the yellow groups, So that's the group where you do the Sentinel node biopsy. The Sentinel node biopsy is positive, so they do less good as the Sentinel node negative group, but they do better than the observation group because you did an immediate lymphadenectomy. And I think that's the main meaning of this trial, and that's statistically significant also for melanoma specific survival. So I hope I got it a little bit. It's a little bit difficult, but I think that's the most important thing. The problem is it true also for head and neck melanoma? So what can we do for head and neck melanoma? Is if you want to do Sentinel node biopsy, you have to have some kind of patterns of lymphatic drainage, and I think there is a very nice study out there that shows that you have that you can predict your Sentinel node biopsy. So we know we have many Sentinel nodes in the parotid gland, but you have it also in level 2A, for example. The thing is, it's a little bit different from mucosal skin, mucosal SCC, that your nodes are a little bit different. You have more facial nodes, just over the facial artery and vein, and you have more, the level 2 nodes tend to be a little bit in the tail of the parotid, just overlying the sternocleidomuscle. So there are different locations than what you probably expect when you're used to do mucosal SCCs. What's the prognosis? There was an overview out of Memorial here. They looked at different centers doing a Sentinel node biopsy, and what was quite striking is that the regional recurrence rate after Sentinel node biopsy and the false negative rate were quite high. So there were around 15 to 30% of false negative Sentinel node biopsy, which I think for a technique is not acceptable, but which there we see a little bit what the difficulties are, or what the difficulties were in the beginning when looking at head and neck melanomas. So the pros for the Sentinel node biopsy is that you identify a good prognosticator. We know that tumor burden in the Sentinel node is a prognostic factor, so you can analyze that. Maybe you can direct patients to adjuvant treatment. It's the best what you can do for regional staging. In those patients with intermediate thickness melanoma, and also in patients with thick melanoma out of the MLC1 trial, I think there is a survival advantage for those who have a positive Sentinel node biopsy and get immediate lymphadenectomy. And the early lymphadenectomy improves survival and reduces recurrence rate. I think that's the evidence. A little bit against Sentinel node biopsy, it's technically demanding. It's not it's not straightforward. You need cooperation with your nuclear physician. Many surgeons try to avoid that because they fear damage to the facial nerve or the accessory spinal accessory nerve. So far, the high false negative rate was a little bit striking. The Sentinel node detection rate lower than what we were used. But I think there is quite new data out of Michigan. I think that's a very experienced group there, and so they were able to prove that in expert hand, when you have enough experience, I think you can have the same results for head and neck as you have it for other sides. So they had a sentinel node detection identification rate of around 99%, which compares very favorably what we see in the large trials for other sites. I think the feasibility, they were able to prove the feasibility. Prognostic value in that trial was the same as we saw in the MLST trial, so there is a prognostic value for a sentinel node biopsy. It's true for head and neck as it is true for other sites. And the accuracy was also good. They had a false negative rate of around 4 to 5%, and that's what we expect with sentinel node biopsy. So that's what we have to achieve, negative predictive values of 95% or false negatives rates around 5%. And that is almost as good as in other sites. Safety is also given. There were no damages to nerves, and if you are used to do you don't need to do a parotidectomy to get the sentinel node out. You can pick that node out of the parotid. It's not easy. It's difficult to identify, but you can do it very safely without damaging the facial nerve. So in conclusion, there are two good. If you want to read all the arguments in favor of sentinel node biopsy, just get this article, this contemporary review, just published in the Laryngoscope from the Michigan group. It's an excellent article, gives you all the arguments, and or the review done in Europe. So indications, I think so. The conclusion is that you do it in Breslau over 1 millimeter. I think that's accepted. If you have Breslau less than 1 millimeter but above 0.75 millimeter, then you have to discuss with your patients if you have any adverse factors like ulceration, etc., etc. Then you have to at least discuss sentinel node biopsy. I think the evidence is not that strong that we have to do it. We recommend it for every patient, but at least you should discuss that with your patients, and usually we at our institution we usually do that, sentinel node biopsy. So the only question that's remaining is, do you always have to do a lymphadenectomy after positive sentinel node biopsy? Here we are still waiting for the results of this trial. And the rate of additional metastasis is around 15%. But the problem is that the pathologic examination is different from what we do to our sentinel nodes. So we don't know if we are overestimating or underestimating the rate, so we don't know. In conclusion, I think what I said, sentinel biopsy also for head and neck melanoma should be standard of care in intermediate thickness melanoma. It should be considered for thinner melanomas with adverse features. I think it should be also considered for thick melanomas in case you have excluded distant metastasis. That's why we advocate a PET-CT in these patients and then brain MRI. It's important for prognosis. Early lymphadenectomy is an advantage for sentinel positive patients, and even in the head and neck area we have the same accuracy, the same feasibility, and the same results in expert hands as in other melanoma sites. Thank you very much for your attention.
Thank you very much for that. Do we have some questions for Professor Stackley? If you'd just like to step up to the microphone and give your name.
Ted Young, Hamilton, Ontario, Canada. If the patient has obvious in-transit metastases within 2 to 3 centimeters, do you still do sentinel node biopsy?
That's a good question. It's quite rare. We would do that. Yeah. But I don't. There's no. I think that there's no evidence to support that. But we would do that. And the next question is, where do you inject? Where do you inject? Yeah. And I think you can decide it a little bit intraoperatively. I think I would first inject the primary site and then see what happens, and at least during surgery with the vital blue inject the second site. But it's rare and debatable. Yes.
Thereafter, you identify the sentinel lymph nodes and send it for the pathology. Do you send it during the operations, under frozen section, or do you wait for the paraffin sections to be performed?
Yeah, you wait.
before
You wait. I think, yeah, there is no there is data against frozen sections, so it's almost impossible for your pathologist to
take over?
to do that without immunohistochemistry. It's different from mucosal SCC.
Yeah, so, in the case of event that you get a patient that was excised outside of the premise or outside your hospital, and the pathology came out to be a malignant melanoma. So do you have a time duration, and it was clinically negative, the neck, according to CT findings or ultrasound. So there a time limit after which you cannot perform lymphoscintigraphy in these cases? At the operation site, I mean?
You mean the patient that had the local excision elsewhere?
Outside, yes, elsewhere. And he didn't perform the sentinel
Yeah.
lymph node.
There's no limitation in timing. The question is, this patient, did he have just excisional biopsy, or did he already undergo wide local excision? Because after wide local excision, it's not so accurate to do the sentinel node biopsy again. But after excisional biopsy, no problem. You do it when you do the wide local excision. You do the sentinel biopsy.
Okay,
but timing is not an issue.
Two questions for you. Would the location and the size of the metastatic disease in the lymph node after sentinel lymph node biopsy alter your management of nodal basing? And the second one, what is your thoughts on the Morton's paper when they discuss the role of sentinel lymphadenectomy and sentinel lymph node biopsy and lymphadenectomy in prevention of distant disease? That was one of the things that was published in the 2014 paper.
Yeah, it's very difficult to. The second was in the presence of distant disease. What was it? Distant disease?
Yes.
Okay, so if you still do the distant disease, no. Okay, that's a good question. I think it's still open. I think at our institutions we if we have a negative ultrasound and a primary with distant disease, so I think just to prevent local complications, we do the surgery. We wouldn't do a sentinel biopsy in these cases. They go. If I got you right, I have a little bit difficult with.
Well, they one of the conclusions that they had was the patients that they go under sentinel lymph node biopsy and then subsequently completion lymphadenectomy, they would probably have a decreased incidence of a distant disease, and their survival was different on that. And if I remember correctly, I couldn't download the paper right now. And so that's what I was going to ask, and to see if there was any consensus on that, whether or not the audience and the panel believes there makes a difference.
Do you understand?
Yeah. So as I understand it, you're asking, does the sentinel lymph node biopsy impact, or the clearance surgery after a positive sentinel lymph node biopsy impact on distant disease?
Okay. Now, because it's very difficult to hear you up there with that microphone. Yeah, that's good. I don't know. I don't really know that.
And how do you guys manage a subcapsular micrometastatic disease to the sentinel lymph node? Do those patients all get a lymphadenectomy?
No. We don't do that for just tiny subscapular or isolated tumor cells. We don't do the lymphadenectomy. Yeah. Sorry for that, but okay.
Can I just ask a question? If it's clearly prognostic, the sentinel lymph node biopsy, but if you believe it's therapeutic, then why didn't the patients with the thick melanomas have any improvement in melanoma-specific survival? It was only limited to the intermediate thickness.
Yeah, I fully agree. Yeah, I fully agree. So that's true. So the focus on the intermediate thickness. That's where we do that. There is some trends in statistics that probably the thick melanomas you can consider that, but I don't think so that there is data that they have improved survival in any kind.
Can I also ask, with you, so you're doing PET CT scans first and then a sentinel lymph node study, what's the incremental value? So if you have a PET CT scan that doesn't show any nodal disease, what percentage of patients would then likely to have a positive sentinel lymph node?
No, that's the same. We don't do PET CT routinely on those intermediate thickness melanoma. I think PET CT is just in case you have a high risk of distant mets. So to exclude regional nodal disease, we do the ultrasound. That's cheaper and it's more accurate. And PET CT is just for patients with proven nodal disease and more or less with macroscopic nodal disease. So it's just when you have a high probability of distant disease. That's it.
Great, thank you very much.